Okay. Well, we certainly want to respect all of your time, so we're going to go ahead and get started. Hi, everyone. I'm seeing mostly familiar names on the line today, which is wonderful. Thank you so much for returning to join us. But for those of you who don't know me, I'm Amy Donahue, and I'm Pivot's Engagement Officer. And on behalf of the team, I want to thank you for joining us for today, which is our 10th edition of this virtual panel series, Voices from the Field. And especially during this time when there are so many critical issues on everyone's minds and hearts and places to be putting our time and energy in the US and across the world, we really appreciate that you're lending your time to us and that you value the work that we're doing. And we're grateful to have your partnership in the fight towards greater equity in global healthcare. So today's the third in a series of three sort of sub-series within this panel session series dedicated to discussing our ongoing clinical activities at each level of care in Ifanadiana District. So 2 weeks ago, we talked about our community health program. Last week, we focused on primary care activities at the health center level. And this week, we will be taking a look at our activities at Ifanadiana District Hospital. So just a few quick things to go over in the realm of housekeeping before I hand it over to our panelists. First, we are recording this session, but you can rest assured that while you can see and hear us, we cannot see and hear you. So enjoy whatever meal you may be having at this time of day in your time zone. Second, if you haven't yet had the chance to submit questions for our panelists today, we'd like to encourage you to do so at any time during this call. We'll shift to a Q&A about halfway through the session. So the earlier in the call you can submit your questions, the better, so that we can get to as many of them as possible. Just use the chat box at the bottom of your Zoom application to message us with your question. And once we do enter that portion of the call, we would love to invite you to join us using your own voices to pose your questions to our panelists. So if we get to your question and Tara says your name, I will enable your mic capabilities. And if you feel comfortable, we would invite you to unmute yourself and present your question. This has been a really, really nice way for us to feel more connected to our community during these times of isolation. And we hope you feel the same way. So if you feel comfortable, great. If you don't, you can feel free to ignore us and we will ask the question on your behalf. And I think that just about covers it for my part. So I will hand it over to our Executive Director, Tara Lloyd, who will be moderating us today.
All right, well, thank you, Amy. And again, everybody for joining. Today, we are gonna hear from three of our key physicians, Doctors Aina and Jessie, who can give a wave. They are our voices from the field today. They're sitting in Ranamafana at the end of a long work day. It's evening. Just rushed in from the hospital, actually, moments ago. We weren't sure they were going to make it. We were going to wing it, but here they are. And then Alicia, who is in Seattle, and she is our Chief Medical Officer. So the three of them will make up the panelists. And I think that it's going to be a really important conversation, and I'm grateful, as Amy said, to have you with us. I do want to say that for Aina, English is a third language, and so we have encouraged him to speak and also to lean on Jesse for translation, however he feels most comfortable. And I need every week to start with our COVID update just to make sure that we're tracking what's happening in Madagascar, even though the conversations we've been having in the last three series, as Amy mentioned, have been more about our care every day, always, than about the pandemic. But I want to make sure people know that the cases in Madagascar are on the rise. Today, the reported case count is 908 with 6 deaths. And things are developing fairly quickly in country. We still do not have a reported case in Ifanadiana District where we work, but it's only a matter of time. The limited number of tests is what we think explains most of the limited number of detected cases. So we can talk about that more, and also preparations at the hospital for COVID, which is really where most of the COVID activity is, if you'd like to, at the end of the call. Before I turn it over to the panelists, I want to acknowledge this moment in time for the world with the pandemic, and for the US right now, particularly with the deaths of George Floyd and Breonna Taylor, with the murders of those two people. I know that everyone knows that the riots and the protests are a call for equity and justice, and it's hard to make sense of this, and it's hard to hold a panel about anything else right now. And I'm sure that you all feel that way, and the fact that you've joined means you're making space in your heart for both. And it probably means that you see things the way that we do, which is that this is all one big question. of basic justice, global health and the lives lost because of poor health systems, and the racial injustice that we see right now in the US, and social justice issues the world over, to me, are all the same thing. I was called to this work 20 years ago with a quote from Paul Farmer, who is a Pivot board member and obviously a Partners in Health co-founder. And he said something that I feel I woke up this morning thinking is true now more than ever. The quote is, "The idea that some lives matter less is the root of all that is wrong with the world." So with that, I am going to set aside the conversation of racial justice and promise you that we're going to bring this conversation back to that when Alicia speaks, because she will be able to tie together the injustice in terms of where we see COVID deaths, the racial injustice that we're experiencing right this week in the US, and in general, global health injustice the world over. And I think it will make a lot of sense. So I really appreciate that today more than ever, you bear with us as we wade our way through trying to have the right conversation in the right time. And I don't want that to diminish the incredibly important work that Aina and Jesse do every day in matters of injustice and fighting that in Ranamafana and Ifanadiana District. So I'm going to turn it over to Aina to present his work, and hope that we can follow that conversation. Jesse will then present hers, and she'll be using a video of the hospital so you can get a sense of what we're talking about in the context, which I always think is a really nice thing, because hospital conjures a different image depending on where you are in the world, and we want you to know where we're coming from. And then, as I said, Alicia will come back and try to draw all of these things together before the close of the hour. We already have a couple of questions. We're grateful for those, and we'll watch more coming in, and I'll try to steer the conversation as best I can and close at 1 o'clock Eastern Standard Time. Okay. So Aina, I turn it over to you to begin your part, and thank you again for coming from the hospital to do this for us this evening.
So, hi everyone, I hope you are well. I'm glad to be with you today. My name is Aina, and I'm a doctor. I did my medical training at the Faculty of Medicine in Antananarivo. After my studies, I worked in private health centers in the capital. In 2015, a volunteer mission helped me understand that many Malagasy people like me still live in places where healthcare does not exist, or they are forced to travel miles to benefit from medical care. That's why in 2016, I joined Pivot as a hospital doctor after a friend told me about the vision and associated activities being supported by Pivot, which were perfectly aligned with my beliefs. In 2017, I became Pivot's first Deputy Director of Hospital Care. My job is to ensure that patients receive dignified quality care and the hospital level. For this, we ensure that visit of hospitalized patients, we receive patients in the emergency room, we provide information and education to patients and families to help them better understand the disease they have. One of my greatest satisfactions is seeing patients return home in good health after being hospitalized. In my role as Deputy Director, I take care of both the well-being of my patients, but also of my teams who work every day so that patients can receive the best possible care during their stay in the hospital. After the establishment of a blood transfusion unit and the infectious disease ward last year, and in order to meet the needs of the community, the focus this year is on setting up additional new services. The first is a neonatology unit in order to improve the management of newborns with medical problems. At the moment, these babies are cared for with other adult patients in the maternity ward. Last month, we reorganized hospital services so that the pediatric and malnutrition services are now adjacent to the maternity ward in order to have a mother and child health complex. We will also set up an acute care unit to better monitor patients in need of close monitoring, such as those with heart problems, stroke, or coma. And we are planning for the development of a basic trauma unit because a national highway passes through the Ifanadiana district, and we often see people injured in the traffic accidents, the majority of which require emergency care. So in response to COVID, the hospital has adopted infection prevention and control measures, such as social distancing, new hand washing stations, the establishment of the pre-screening area, and additional triage. Fraud, which all people who visit the hospital must pass to answer a series of questions and have their temperature checked with a touchless thermometer. This helps to ensure the safety of patients and healthcare workers. So, although we do not yet know of any cases of COVID in Ifanadiana district, measures are being taken on ensure that any potential cases are appropriately managed. This preparation includes staff training, additional infrastructure, relevant medical and non-medical equipment, high-need infection control measures, and additional human resources. Of course, all of these activities are carried out in close collaboration with the Madagascar Ministry of Public Health. So thank you guys. It's been a real pleasure to share this with you.
Beautiful. Thanks, Aina. Jesse, we'll ask you to go next, please. And you are going to queue up your video, which we really hope is going to work. Amy's going to run it in the background while you talk.
Pretty exciting having some video on board. I'll try to live up to it. So Aina is definitely the expert at the hospital level. I am the very, I'd say relative newcomer, but I'm really just the newcomer. I got here exactly 2 months ago. After kind of a year of puttering around doing a number of global health projects, this dream job landed in my lap while I was working with PIH in Malawi. And so I rushed in and I slipped under the border just as the airports were closing. I got here the day before the borders closed. So after 2 weeks of quarantine in Tana, I finally made it down here. And I've been working at the hospital alongside Aina ever since. Yeah. And it has been a steep learning curve, and I would not be able to do it without the help of Aina, so thank goodness for him. So a little bit, so you can see there's a very cool aerial view of the hospital, but I think what's going to be fun about this video is you'll get to see the hospital a bit through my eyes. As I was first arriving, I think all of us, like Tara was saying, a lot of us have seen different hospitals in lots of different settings, and really just kind of getting an idea of what it felt like. And I think one of the first things that I was really struck by was that we have this incredible ambulance system. I mean, I'm really, really impressive that we have this ambulance system that will come and bring in emergencies. A lot of these are births, and a lot of these, as Aina mentioned, are traffic accidents because there is a highway that goes right through our district, and it is so dangerous. So we do see a lot of births, a lot of traffic accidents, but then just any other kind of standard emergencies. But one thing I was really taken aback by was that despite the fact that we have this really novel and well-functioning emergency referral system and ambulance transfer system, is that our patients have to still walk and travel somehow miles and miles to get to our doors. So I thought that was already one of the first barriers I saw to healthcare. Is just there's a huge spread of patients throughout the district. And we have that national highway that we keep talking about is the only paved road. So it's incredibly difficult to get to our hospital. One thing that's also I thought was really interesting is the first time I saw a patient being walked to the hospital, they were accompanied by 20 different people from their village. I thought that there was a party going on or something, but then the person who was driving me at the time explained to me that when people come to the hospital, often they are accompanied by a very large number of people, and in fact shows how well loved and supported they are. Even within the hospital, we actually have 2 people at any given time who stay with the patient because they're actually in charge of cooking and doing some of the laundry for the patients. Now, one of the really cool things that Pivot has done recently is started to provide meals for the patient and one of their accompaniers, which makes a huge difference, I think, in how long people are able to stay and how well their visit goes while they're there. But it's still really important to have 2 people there just kind of for general support of the patient. So then once you get into the hospital, the next thing I noticed was there are quite a number of wards. So Aina mentioned we have kind of our new maternal fetal health center where we have maternity right next to neonatology, right next to pediatrics, right next to CRENI, which is malnutrition. Very cool. Then there's the operating block, which is kind of actually where the admin area is, but that's just where it is. And then we have our emergency room, which is just, of course, as the ambulances come careening up the driveway, they turn in, and that's where the emergency center is. And where our pediatric unit used to be, we just started this chocage room. So that's our intensive care facility, which we're still in the process of equipping right now. Right now, we've got the beds. We're still working on getting the monitors and the oxygen necessary to really support patients there. So really what it provides right now is a place where people can be watched very closely. Finally, as the last thing I saw, but kind of one of the coolest parts of our hospital is our lab. Our lab is so outfitted, I cannot even tell you. And we do have a blood transfusion center, which in a region where malaria is so prevalent and so deadly, this is incredibly important. So the blood bank has been just fundamental in a lot of the treatment of our patients. And unfortunately, we still have we still have a few deaths from malaria because we either run low on blood or people are O negative. Everyone here is positive. So when we have the very rare O negative patient, it's very difficult to find donors. But still, having worked in other low middle income countries, it's such a privilege to have a blood bank. It's really amazing. So those are my first impressions of the hospital. And then, over time, I got to be impressed by our actual team. But that leads me to my actual job, which is as hospital care mentor. So our team is excellent. We've got 7 doctors. We have 7 doctors, and then a number of paramedical staff that help us out. And we round down all the patients every day. And that's kind of the individual level of care. So my job as a hospital care mentor, I do round with patients, but my job is to kind of step back from the everyday patient care that happens and see if there are any kind of bird's eye view projects that we can take on. And just because that sounds super vague, I thought I'd come up with a couple of projects that we've been kind of talking about as we got started, just to give you an idea of what we're doing. So just 2 projects. So the first one is our Hepatitis B project. It's a pretty well-known fact that we have a lot of hepatitis B in our region. In fact, in Madagascar, there's about a 25% prevalence of hepatitis B, which is enormous. So we knew that. We knew that we saw a lot of patients with hepatitis B. We also knew that we did not have a good way to treat them, and there wasn't much we could do about it. So one of the projects we started was talking to the lab to figuring out exactly what our prevalence is. Well, when I say exactly, we have a rough estimate that we have about 20% prevalence of hepatitis B in our area. Then it was figuring out how to source tenofovir. Tenofovir is available at the hospital, but only as part of an HIV program. So it was trying to get tenofovir to be available and givable at our hospital for patients who are not HIV positive. And that's where our hospital care is. Then the other fun part is I get to work with other levels of care. You guys have already heard from primary care and community care. One of the really important parts of that is referring people to the hospital, making sure that babies are vaccinated, and making sure that we can ensure that people continue to receive tenofovir. So that's a very cool project. It's very multidimensional and very multi-level. And that's kind of one of my projects. Then another one, we've been working with primary care to work on a massive screening for hypertension and diabetes. And this kind of came about at the same time that we were realizing that we were seeing a large number of catastrophic strokes at the hospital. People who are basically end stages of diabetes and hypertension. Well, by the time they get to our hospital, there is not much we can do. We can give aspirin, we can give atorvastatin, we can control their blood pressure, we can control their sugar. But at that point, it's too late. There's just, people are going to get better or not on their own. So one thing we're working very hard with is doing a massive screening of people in the community to try to detect new cases of diabetes and hypertension. And one of the things that we're navigating is how much care should people receive at the hospital level versus how much they should receive at the CSB level, at the clinic level. And that project is in its infancy. We literally just started, but I think those are 2 really good examples of what a hospital care mentor does. There's didactics, but there are also kind of these overarching projects where we can get a little bit more cooperation between teams, and in that way, involving lots of other different parties, make sure that hospital care in and of itself is just excellent. That's my spiel. Thank you, Tara. Back to you.
Awesome. Thanks, both of you. That was really nice. And I hope for the audience, seeing the hospital while they spoke was an enlightening thing. I see we have a couple people on the line who have worked in the hospital in the past, so you guys may have something to say about how nice it looks. And also one quick comment that it looked empty because we did not film patients in their beds, obviously for confidentiality purposes. So they particularly did that video making sure that they only got to places where we couldn't see faces out of respect. Okay, I'm going to hand things now to Alicia for her remarks, and then we'll turn things over to questions.
Thanks, Tara, and thank you, Aina and Jesse. It always makes me happy to see your smiling faces and know that you're taking really good care of all the patients in Ifanadiana, particularly while I'm stuck here in Seattle. So you just heard from two true voices from the field as part of this Voices from the Field conversation that we've been having over the last couple of months. As I mentioned, I am here in Seattle right now. I'm in my comfy house, and I have been asked to take us through more of the global perspective and take a step back from the direct work in the hospital to how it links in with all of the other important work that we're doing. And I feel like this is a particularly fraught time for taking a global perspective on almost anything. Certainly the events of the last few months related with the COVID-19 pandemic have underlined just how interconnected we are as a global community. At the same time, I think it would be remiss of me not to at least touch on the critical dialogue that's kicked off in the United States in the last week since the tragic death of George Floyd, of Breonna Taylor, and unfortunately too many other people before them. But you might ask, how does this tie into a conversation about district hospital care in a rural part of Madagascar, many thousands of miles away? And I thought about this a lot last night, and if you bear with me for the next few minutes, what I'm going to try and do is explain how I think these things all are fundamentally linked in an important way to talk about. So first, this webinar rounds out a conversation that we've had around the 3 different levels of healthcare that Pivot's supporting in Ifanadiana District. So first, we started a few weeks ago with a conversation about community health and the really integral role that community health workers play in linking remote communities, such as the ones in Ifanadiana, with basic health services. And then last week, for those of you who joined, we talked about the key role of primary care. So those are the regular clinics that people go to for their daily problems on an outpatient basis. And in many ways, primary care can play a preventive role so that people don't get sick to the point that they require hospitalization in some of the ways that Jesse was just describing for us. So now today we've turned to hospital medicine, and I wanted to take a moment because the topic of hospital medicine can seem somewhat sterile and even foreign to many people who aren't, like Jesse and Aina and myself, doctors and spend a lot of time in hospitals. But I think most of us have had the experience of either being hospitalized ourselves at some point in our lives or of being with friends or loved ones when they have been hospitalized themselves. And I think if you've had that experience, you'll agree that there's a real feeling of vulnerability during that time. You're very dependent on these strangers that you don't know. You're dependent on a system and an institution that you don't necessarily understand. And that's quite unusual, I think, in our day-to-day lives. So I want each of you to take a moment right now and really think about any experience you've had, a time like that in your life when you've spent some time in a hospital and what that felt like. Now that you have that in mind as context, and you've heard from Jesse and Aina some of the things that we're doing to help those people in this uniquely vulnerable position who require hospitalization in the Ifanadiana District. Now I want to take us beyond that conversation to the work that happens, that Jesse was alluding to connect these different levels of healthcare. Because not only is it our job to set up this neonatal ward and make people comfortable and help them with access to care and good quality care at the hospital, but it's also our job to work with the government to make sure that those different levels of care, the community health programs, the primary care programs, and the hospital programs, that they can all work together seamlessly, and that people can go from one level of care to another as needed. And I don't think that's something that we think about a lot in developed countries, but it's critically important and something that often doesn't function really well in resource-poor settings like the one we're working in Madagascar. And I'll give you a couple examples of why this is so important. So first of all, let's take a really strong community health program. You have well-trained community health workers. They're able to go from house to house, identify pregnant women, identify children who have malaria, and they know what to do in that case. But if they have a really sick child with malaria that needs referral to a hospital, and they bring that person in for care, and it's a broken hospital that doesn't have trained staff or doesn't have essential meds, or doesn't have any of the many things that go into making a hospital functional so that it can treat that child, that's going to discredit that community health worker, and that whole system of community health over time will be discredited by the fact that there's not a functional hospital to refer patients to. On the flip side, if you have a really functional hospital and a really functional set of clinics that have all of those important things, but there's something missing at the community level. So recently what we saw in Ifanadiana in Madagascar was that there was a stock out in rapid malaria tests that the community health workers were using. And so what happened was, instead of them diagnosing under 5 malaria early on and preventing kids from needing to go to the hospital, what ended up happening is they didn't get diagnosed in the right time frame. Those kids got much sicker, presented to the hospital with severe cerebral malaria, having seizures, et cetera. At that point, it's much harder to manage those cases. And frankly, some of those kids don't make it in time. So really, we are working with the government to make sure that all of those pieces are strong and functional and are connected appropriately. And sadly, this isn't the case in many places. In many parts of the world, hospitals are actually thought of as the place to die. I remember one hospital in particular that I've worked at in Sierra Leone, where I literally heard that time and time again, like, this was the place people would come to die, and now people are living, and how incredibly impactful that is, and how different that is from our experience here in the United States. So I think there can be a somewhat false discussion for, I think many of the people on the line are involved in some capacity in global health. And I hear a lot about the need for education and behavior change in these communities. And I've seen millions and millions of dollars devoted to education and behavior change. And while I think that public health education is critically important for all of us, I also think that it's a false argument to say that we need to educate the rural poor about using healthcare services. I think everyone knows if they're sick or a family member is sick, and everyone, no matter who you are, wants to access care for either yourself or your loved one. The problem is it has to be affordable, it has to be accessible, it has to be appropriate, and it must be dignified. And so many of those pieces are lacking in so many of the healthcare facilities and systems around the world. And if more of that money that is put towards education and behavior change were put towards dignifying those facilities, I think we would see better health outcomes than we're seeing right now globally. So Amy, can you please pull up that first slide? I just have 2 quick images that Amy's going to share for us while I'm talking. So this first one, this is Anala Marina Health Center, which is in the northern part of our district. It's a 2-room facility. This is one of the rooms. And this is where people go for their general care. So I think this, better than any words I could use, highlights my point of no matter how much money you spend telling people it's important to deliver in a facility, would you want to deliver in this facility? I personally would not. I wouldn't want to get any care in this facility, and I certainly wouldn't want to walk for 6 hours in order to do so. So I think that is the decision that many people face. And what we're doing at Pivot is working in partnership with the Ministry of Public Health to improve all of these levels of care and to address facilities like this so that people don't have to face this decision of, is it worth walking 6 hours for care in a place that looks like this, where they probably don't have the medicines available. And at this point, I want to bring us back to the conversation about what we're experiencing in the United States, because this is where I think things are linked. As a result of the real pain and anger that's been provoked by the senseless death of a Black man in Minnesota named George Floyd, and Breonna Taylor and many others before him, we're having this long overdue renewed dialogue around structural racism and social justice in this country that I think is critically important. What happened last week with George Floyd was an individual example of a fundamental violation of justice. And anyone who's watched the video, that's very apparent for you. At the same time, there are clear racial disparities in general health outcomes across the United States in many different categories. And we've seen that again with COVID-19. We're seeing that time and again in cities around the United States, people of color may be infected at lower rates than the general population, sometimes higher rates, but in every case, they have significantly higher mortality rates. And often it's people of color who are the people on the front lines who are delivering services and so exposed on a daily basis to COVID. And we're talking about issues now that have really been around for hundreds of years. That's in the United States, but I think on the global scale, those same trends are happening. And there are even larger forces of structural violence that plague countries like Madagascar, others in sub-Saharan Africa, and other resource-constrained countries around the world. So thanks, Amy, for bringing up that slide. There's a lot of focus on quote-unquote aid to Africa. And I think often that conversation focuses around the need for charity to poorer countries. We have these positions where we have better healthcare systems, we have more opportunities, we have more funding, and so we should give back to these poorer countries who are, for whatever reason, in a worse position. But, and there's a lot of recognition generally amongst people about the profound injustices that were inflicted on Africa and the people in Africa during the colonial era, but we don't hear a lot about the ongoing structural violence that perpetuates these injustices. So this is an image showing roughly $30 billion of aid flowing into Africa each year, which really pales in comparison to the $192 billion in aid that's funding that's extracted from Africa in both legal and illegal ways each year. Now, this figure is from 2014, and one can argue about the exact dollar amounts. You can point out maybe certain things in this diagram that don't seem accurate or should be depicted in a different way. But I think I wanted to use it because it makes a clear point that's very important. And the point is that we have an exploitative and extractive relationship with Africa that started hundreds of years ago, but continues on to today. And it's that relationship that perpetuates these inequities that we see play out in the healthcare systems in countries like Madagascar. And part of that history and ongoing current history is why we see clinics like the one that I showed you a couple minutes ago. So my final point is that these seemingly unrelated inequities, what's happened with George Floyd and other Americans, African Americans in the United States, the way the COVID-19 pandemic has differentially impacted people of color in the United States, and the stark inequities in healthcare systems in Africa and other resource-poor countries around the world are actually all a part of the same process of structural violence and institutional racism that has been perpetuated both here in the United States and globally for centuries. And in fact, I think it's because of this ongoing structural violence and these deep-seated inequities that women in rural Madagascar have to choose between delivering on a dirt floor at home or delivering in what's maybe a marginally better broken floor of a health center like the one I just showed you. And I think it's up to all of us to have this dialogue, to promote the dialogue about the global situation in the same way that people are raising their voices right now about the structural violence happening in the United States. So that was a lot, but I thought it was important to at least start that discussion. And I want to turn it back to Tara and our other panelists.
What should we do?
Oh, sorry, I've been visited by my homeschooler. Okay, Alicia, thank you. That was brave. And I know that we're getting some conversation happening in the chat channel about it. I think what I'd like to do is pause to recognize what you've just said and maybe ask Aina and Jesse if you would like to say anything further about what Alicia has just brought to the forefront about the daily work of saving lives in Madagascar, about the inequities around COVID, about racial injustice. Anything that's on your mind. If you don't have a comment, that's totally fine. And then I am going to turn to questions from the audience. The ones that were submitted before we began are fairly technical about the hospital itself. And I'm going to try to figure out if that's the right way to go or not. These are like real-time conversations. So Aina and Jesse, would you like to comment before we go to basic questions?
Yeah. Aina and I have actually kind of been just chatting in French as we go. Alicia, thank you so much. That was beautifully put. And there's nothing I can add substantially to what you just said. We just agree very strongly with what you say. I did want to say that I think one of the things that we both find incredibly important about our job is that we do want to be part of a system that delivers absolutely excellent care to people who are simply not used to receiving excellent care. And it's not because, you know, it's the best we can do. It's just we want them to have the best. Period. And I think it's very, I think we find inspiration in our patients and in our team because we are able to kind of participate in that struggle every single day. And we're very happy to do so. So Alicia, thank you for putting it so beautifully. Really, thank you. And sorry to talk for Aina.
Yeah.
He's just shy about talking in English.
Aina, do you have anything you could say in French you want to have Jesse translate or?
Quoi déjà?
Sur le fait de travailler aux hôpitaux et de la lutte pour la justice sociale.
Pour ma part, c'est difficile vraiment de voir que des Malagasy comme moi souffrent vraiment d'être loin d'un centre de santé. Comme Alicia a montré tout à l'heure, il y a des centres de santé qui n'ont même presque rien du tout dans le district. Et pour moi, c'est vraiment la chance de pouvoir aider vraiment les miens. Et c'est aussi la chance d'avoir des personnes qui veulent soutenir vraiment les Malagasy dans les soins qu'on leur donne et qu'on peut leur donner. C'est une chance vraiment pour le district, mais je pense qu'on ne veut pas rester dans le district, mais plus tard, on va couvrir Madagascar tout entier pour vraiment aider les Malagasy, ne soit que pour la santé, mais aussi peut-être pour beaucoup de choses plus tard.
So sorry, I'm not a simultaneous translator. So for those of you who don't speak French, it is difficult for me as a Malagasy person to see that there are people who travel just incredibly long distances to arrive to centers like the one that Alicia showed us a photo of. And it's really inspiring for us to be able to work as a team in the hospital to be able to provide better care for these people. One thing that our goal is going forward is to be able to provide this care at a national level, not just a regional level. Yeah, that was a bit of a summary, sorry.
Thank you. I want to say that Aina and others make a huge sacrifice in the work that they choose to do. Aina is a father, and he could choose to live in the capital and educate his children in a stronger school system than is available in rural Ifanadiana, or have a job that's less demanding. You know, you witness a lot of loss of life working in these centers before they can be improved, and as they're being improved, and even after. And it's just brave to do that day in and day out. And I always think of our staff who make the choice to live where we're all working and what that means. So I think I will turn it now to a couple of questions. We've had a really beautiful quote from Nancy, who's on the line, saying, "Justice is justice is justice." I agree. So with that, we are going to talk about the justice of having access to ultrasound when you need it. Charlie Mead, a doctor who was a volunteer with us a couple of years ago and a real inspiration. Can we ask you to ask your question aloud? And I'm going to have this be for you, Aina.
So I don't actually have a real question. I just want to say how overwhelmed I am by all of the progress you've made. I'm sitting here with tears in my eyes of just absolute joy of what you've accomplished. And I just want to say, hey, Dr. Aina, you're English. Phenomenal, phenomenal. My question was a tiny question, and it doesn't even really actually need an answer. I just wondered if ultrasound was still part of your daily, treatment of patients. But you know what? Even if you said it wasn't, what you guys are doing is just fabulous.
This is my favorite part of Voices from the Field. Thanks, Charlie. Aina?
So, hi, Charlie. Non, vraiment ravi d'entendre ta voix, ça fait super longtemps.
Great to hear from you. It's been a while.
I can understand.
Oui, on utilise toujours l'ultrason et beaucoup plus qu'auparavant même. Elle nous aide beaucoup, vraiment. À l'hôpital. Non, l'échographie, mais pas Jessie. Ok, l'ultrason nous aide beaucoup. Et là, on a déjà plusieurs personnes qui peuvent manipuler. Et de temps en temps, on a recours vraiment à l'ultrason pour confirmer les diagnostics au niveau de l'hôpital. Certes, il y a maintenant quelques problèmes, mais je pense qu'on peut y remédier pour que cela fonctionne vraiment à 100%.
Yeah. So what he's saying is that we do use it every single day to help with our clinical decisions. And in fact, now we have more than one person who can operate it. We have an official echographer, but we have a number of doctors who are able to use it every single day for diagnostic and therapeutic purposes. We do a lot of paracentheses there. And it's incredibly helpful. I'm going to add something to what you just said, because the CT scanner is incredibly difficult to get to. So if there's something we can resolve with the ultrasound, that saves everyone a lot of time, energy, and money. So very helpful.
That was definitely the goal. So wonderful.
Yeah.
Thanks for being the part of the beginning of that, Charlie. Alicia wanted to add something as well.
Yeah, and hi. Sorry, go ahead. Sorry, I didn't mean to cut Charlie off. I was just going to add that one of the things Charlie helped us set up a few years back was ultrasound training from an excellent group based out of South Carolina. And Charlie, I wanted you to know that we're back in touch with them and are planning with them that they're going to do additional training for us in Ifanadiana District for our staff, so that more staff are better trained in ultrasound. And I think that training and capacity building are some of the key things for addressing some of these structural injustices that we've been talking about. So I just want to make that point.
Fabulous. I wish I was still there.
Can I say, Charlie, I've never met you before, but everyone at the hospital says you're really cool. So rock it out.
I wish I was still there. Tara, we can't hear you.
Ooh, I did the thing everyone does on Zoom. I said we're really grateful for everyone who has helped build Pivot, and you especially, Charlie. Thank you. I'm going to go on to Norma, if she's with us. This is another of my favorite things about Voices from the Field, is that we have a really strong showing of moms. This particular mom is the mother of Dr. Laura Hall, early medical director and current Pivot board member. You all heard from her last week in discussing primary care. Norma, I think your question will best be for Alicia, but let me listen again and we'll decide.
Well, can you hear me okay? Great. Hi, and I'm really proud of all of you. as you well know, but this is great. And I appreciate the tie-in you did today of what's going on in the United States to really global health and all the experiences. You did a beautiful job of it because it's a very complex subject. However, I'm sorry to say that I don't know what my question was because I did it when I registered 3 weeks ago. So I'm embarrassed, but could you read what I asked?
Absolutely. I think we haven't figured out this glitch. We've done this to a few people. I'm sorry. Amy, why don't we have you read Norma's question?
Sure. Hi, Norma, and thank you for participating again. It's always nice to have you on the line. Your question was simply, how supportive is the Ministry of Health of the efforts of Pivot?
Well, that's what I thought it was, but I wasn't, you know, I couldn't remember if that's what I asked, but it's basically, and I think you've touched on it anyway. And I guess the other thing is that I probably has been answered before, but I'm still wondering how, and switching back, and I know it's a little off topic, but with COVID-19 and maybe other things that might come that are pervasive, how does the word really get out? Since you live in such a remote environment from your patients, how do they really find out what they need to know, to be aware of? So it's kind of both sides of the coin.
Mm-hmm. Or that facilities have been improved and look different than that picture we showed. Okay, I think starting with Aina and then going to you, Alicia, makes sense to me. If Aina has gotten the question clearly.
The first question, yeah?
Yeah.
The Ministry of Health? Yes, absolutely. Donc, comment est-ce que le ministre de Santé nous soutient?
Pendant notre activité, puisque nous travaillons dans l'enceinte du travail du ministère de la Santé publique, donc nous sommes obligés de collaborer ensemble. Il n'y a pas vraiment de mauvaise collaboration. On collabore super bien avec eux.
So yeah, so we, donc, sorry, I was about to speak in French there. So we are actually, because our hospital is actually half run by Pivot doctors, half run by the Ministry of Health doctors, we are forced to work with them on a daily level, but fortunately for us, we have very positive collaborations with them and we haven't had any negative interactions at the hospital level so far.
Ok, du coup, nous, il faut qu'on avance toujours ensemble et qu'on ait les mêmes regards sur comment et où on va amener le CHRD d'Ifanadiane, l'hôpital de district. Et pour ça, le leader du CHRD et nous-mêmes, on a le même œil vraiment pour mener l'hôpital d'Ifanadiane en tant qu'hôpital modèle à Madagascar.
So in the interest of moving forward with all the projects that we're doing, one thing that's really important is to make sure that along with the medical director, Bruno, that we have the same vision of what the future of healthcare in Madagascar should look like, not just within our district, but also as we move forward on a national level. Yeah. That's it.
That's great. And then let's take the rest of Norma's question with you, Aina, and then go to Alicia for both parts. So the question about how do people in the community find out about services, about COVID sensitization.
Sur ce qu'ils doivent faire dans le cas d'une maladie, par exemple.
Actuellement, au niveau de l'hôpital, on a plusieurs équipes qui y travaillent vraiment. Il y a les équipes médicales, mais il y a aussi les équipes non médicales qui, comme les agents, les équipes sociales qui dirigent les patients vraiment au niveau de l'hôpital, qui leur montrent où ils doivent aller et comment ils doivent agir au niveau de l'hôpital. Mais
je vais traduire ça, mais tu veux dire aussi comment ils savent quoi faire au niveau communautaire. So at the level of the hospital, what we have are the medical people work with the patients to really educate them on their diseases and how they should work moving forward. We also have a social team that is based at the hospital that is integral in getting patients to know more about their follow-up and more about what they can do to participate in healthcare in the future. But at a community level,
au niveau communautaire aussi, on prépare déjà les populations sur les sensibilisations à faire presque tous les jours sur comment vraiment vivre pendant les séjours au niveau de l'hôpital. Donc, c'est comme à la maison, mais ici à l'hôpital.
Et ça, c'est l'équipe infirmière ou sociale ou agent communautaire?
Ce sont des équipes infirmières et sociales aussi, agents communautaires.
So at the level of community, we actually have teams that go out into the community and speak with people individually and as groups. So, you know, kind of like an orientation session. And they're called our sensibilization teams. And they can talk to people about any number of instances. Most relevant to hospital care, they teach people how to go to the hospital. I mean, you're supposed to bring bedding and food and necessary equipment, but also they can talk about any number of subjects. So recently there's been a lot going out about mask wearing for COVID and social distancing in COVID, but also hypertension, diabetes, anything that we feel that the population needs to know about. Our sensibilization teams can go into the communities and speak directly with people. Other than that, just to add to that, a lot of people get their information from TVs, but obviously we have no control over that content.
All right, thanks to both of you. Alicia, do you want to say anything? I think this will be the last question that we take. So about either part of Norma's question.
I guess I would just say on the Ministry of Public Health piece, I think that's something that we're actively thinking a lot about, because Pivot was founded on this ideal of really not setting up separate structures, but supporting the Ministry of Public Health in the work that they're doing in their own facilities. They're not our facilities. We're there to provide additional support in areas like training and staff and essential meds and equipment, et cetera. But I think we've realized lately, as we've been having more of a dialogue at the national level, that the national government maybe isn't as familiar with the work that we're doing as we would like. And so we're trying to be introspective on that and think about additional ways to engage and increase that communication with them. So for example, even today in a staff meeting, it came up, we're working on finalizing a 3-year plan, and you know, that it would be good to give that 3-year plan directly to some of the key ministerial officials and discuss it with them and have a dialogue and have certain ways of doing joint work planning at the district level and with key national officials. So that's what I would add.
Okay, thank you.
Well, great. So I'm going to take the last 5 minutes to close, not just for today, but I'm going to wrap up the first 10 voices from the field that we have had. We are going to take a pause now and resume sometime in July. We're going to focus on at site, we're focusing on the ramp up of cases in Madagascar and the additional attention that is needed in our district, and also momentum that we have supporting the creation of a regional lab for PCR testing. So what we'd like to do is say a huge thanks to everyone who has helped us have these 10 opportunities for our community to get to know the frontline pivot work that we're doing and the people that make that possible. To me, it's been a real silver lining of this strange period. We'll resume in July when we were planning to have what we called Family Immersion Week, where people joined us in person with their families in Madagascar. That can't happen now. So we'll be able to offer something much more broadly to people who wouldn't maybe have been able to join us. And we're thinking about that now, so stay tuned. And then as we have more to report on the COVID response front, which is why we began the series, and also on the science side, we will reach out and let you know and invite you back to this conversation. So I want to just say that as Pivot's leader, these last few months have been a really interesting, soul-searching time. When COVID first hit, I thought a lot about many of our supporters in Long Island who were being devastated by COVID and other parts of the US as it began to happen around the world. And I started having this sort of inner dialogue about, is it appropriate to still talk about our ongoing work or to have a session about Madagascar with people who are living this in Long Island? And it felt like, of course it is, because this is finally a moment where we really are all in this together and where those differences don't matter at all, and where people maybe for the first time have the kind of empathy from lived experience that we're often talking about in terms of being a bridge from the health inequities that we witness in Madagascar to what that would be like here in the US or otherwise. And so it kind of began this dialogue for me about, if not now, when? If a global pandemic isn't the right time to talk about domestic and global health inequities, then when would we ever have that moment again? And that we really need to lean in as a community and fund our local initiatives and our food banks, and also fund organizations that do the kind of work Pivot does, or if it's not money, it's time or talent, whatever it is that you're giving. We really are grateful. And that began sort of the COVID dialogue of the last couple of months. I've been very grateful for. Our supporters have really showed up in terms of not turning away from an international organization because they have a domestic pull. They've made room in their hearts for both. And now this question of justice and this week in America just feels again to me like, if not now, when? When would we talk about injustice in the way that, that Paul Farmer's quote that I opened with calls us to all think about? The idea that some lives matter less is the root of all that is wrong with the world. For me, that became really personal when I became a Peace Corps volunteer 20 years ago, and I learned the acronym child-headed household. I was part of a health response in Lesotho in the late 90s, early 2000s, before there was treatment for HIV, and we were watching people die in an unimaginable way, and the children that were being orphaned were being organized by aid organizations, and the term child-headed household and the acronym OVC, Orphans and Vulnerable Children, became a part of that vernacular. And I was horrified that we would have to create language to talk about something so devastating, and then sort of attempt to do something about it, but not nearly enough, was how it felt to me as a 21-year-old living that. I know I'll just share that personally right now, this moment is quite emotional for me as well. My sister, who's just not quite 2 years younger than I am, is a police officer here in Lexington, Kentucky, where we live. I'm sure you know that Breonna Taylor's death happened in Louisville, and so things here in Kentucky are quite tense. And she works nights, she's a single mom, and she's scared, and I'm scared. Her partner is an African-American man in the Chicago police force who we all love dearly, and we're scared. So I just want to say that any kind of work and life distinction that I used to be able to make, where I would think like, I pour all my heart and soul into Pivot for 9 hours a day, and that's my contribution to inequity and injustice fighting in the world. And then in my free time, I am free and I spend it with my children, and I notice birds and flowers, and I try not to take on the burdens of the world. That is all blurred right now, and I suspect it's blurred for everyone. And I'm hoping personally to take that as an opportunity to grow really deeply in my leadership and in my being a mother, and in the way that Pivot is showing up in the world. And the urgency of now feels very clear, and it's upon us. And I feel grateful for every one of you on this call, because I know that we are all doing our part. So thank you. And we look forward to having you rejoin us over the summer as we get ready to present another one of these sessions, and for everything that you do to fight injustice every day. Aina will say Valuma, Misotra, and wave goodbye.
Valuma.